today. And I'm going to just try to add to the excellent presentations that we've had so far about thymic malignancies, focusing on what's new in radiation oncology for these tumors. So I'm going to follow primarily the Masoka staging. That's what we usually refer to in radiation oncology. And we will just go through the different stages of thymoma and talk about the indications for radiation in various settings. As we've discussed already, because thymoma is a pretty rare malignancy, there is relatively limited data about what to do. And so the majority of the series that we look at are small. Many of them are retrospective. Many of them have significant limitations. But I think by 2018, we have seen some fairly clear trends emerge about the role of radiation. And one of them is that for stage 1 disease, where disease is sort of by definition being stage 1 is going to be resectable, that the indication is not there for doing radiation. And so the data that we're looking at here is actually from 1986, but things have not changed significantly since then. And what we can see in the panel on the right-hand side, looking at recurrence-free survival for stage 1 versus stage 2 and 3 disease, is that patients with stage 1 disease after a gross total resection do very well, have a very low risk of recurrence, excellent survival, and the addition of radiation does not contribute or add to those excellent outcomes. There's actually only one randomized trial that has been done in thymoma, again because of how rare it is. And this was a very small study of patients with stage 1 thymoma who were randomized to radiation versus radiation, to resection versus resection followed by radiation. And in both groups, progression-free survival was 100%. And this forms the basis for this recommendation that we don't need radiation in this group of patients. The next data series that we will look at is a SEER data set, which I mentioned in the prior talk. SEER is a Medicare claims-based database that goes back very far. Because of the fact that it's based on claims, insurance claims, it does not have a great deal of detail about the types of treatments that are given. And so it's viewed as an excellent source of data for very rare tumors like thymoma, where we don't have a tremendous volume, because it's one of the few ways that we can really get large numbers of patients together into a single data set. But it's also understood to be a very challenged data set because of the fact that there's not a lot of detail. So this series from the SEER database looked at 900 patients, and they're categorized as localized disease versus regional disease. And the SEER data set does that a lot. And the localized versus regional doesn't correlate perfectly with the Masoka staging. But we can view localized disease as generally very early stage 1 and maybe 2, and regional as more stage 2, 3, and 4. There was also heterogeneity in this group with respect to the treatment, like some having radical surgery with an R0 complete resection, and others with less extensive surgeries. And this is looking specifically now at the group of patients with stage 1 disease and long-term survival. And again, we see that there's no difference with the addition of radiation, confirming in a larger data set what we had seen before. Now moving on to the regional, what's considered regional in the SEER data set, which we think of as likely stage 2 and 3 disease. This is the situation where we start to see a potential benefit with the addition of radiation treatment. And we look at the panel A, the 5-year overall survival. We see an improvement with the addition of radiation in this group. So we think of the leap from stage 1 up to stage 2 or 3 disease as a pretty significant leap. All of this data that we've seen so far really calls out stage 1 as a uniquely sort of low risk profile of a thymoma, and immediately when we get into stage 2 disease, the risks seem to be higher. And for most of the studies, stage 2 and 3 have been grouped together and have clearly kind of a generally worse prognosis. This, again, is some early data looking at the differences between stage 1 versus 2 and 3 disease. And if we look at the panel on the right, this is looking at the benefit of postoperative radiation therapy in patients with stage 2 and 3 disease, looking at the extent of resection. So if we see the blue line on the top is gross total resection with the addition of radiation, and then the red line moving with a poorer relapse-free survival is gross total resection without radiation. And so what we can see, first of all, is that in this data set, there does seem to be an advantage to the postoperative radiation therapy. I think we looked at these images previously, but just to highlight the difference between stage 1 and stage 2. In stage 1 disease, we basically have thymoma that is confined within the capsule, and it may either have an area where the capsule is absent, or it's begun to penetrate into the capsule, but it hasn't penetrated through the capsule. And in stage 2 disease, we start to see penetration all the way through the capsule. In radiation, we do think of a difference between stage 2A and 2B, where in stage 2B, we get really into the invasion through the capsule and into mediastinal fat. We don't have a lot of data because of the rarity looking at differences between stage 2A and 2B. But most of the series looking at the stage 2 and 3 disease kind of are focused primarily on patients with stage 2B disease. So we think of invasion into the mediastinal fat as being kind of an important risk factor. So again, looking at patients with stage 2 and 3 disease, we've seen some early data looking demonstrating a potential benefit of radiation therapy. But up until recently, the data has really been very conflicted. So there are 2 different series that I'm going to present. This one was published in Annals of Thoracic Surgery in 2003, grouping stage 2 and 3 disease together. And patients had surgery, majority of them followed by radiation therapy. And we'll get to stage 4 in just a little bit. And this panel just shows us, first of all, as we've seen previously, that survival does vary with stage. Survival does go down in stage 3 and certainly in stage 4 disease. And as we heard in our prior presentation, surgery is definitely the backbone of the treatment. So in the panel on the right side here, we can see that survival overall varies with the extent of the surgical resection. So the first kind of take home from a radiation perspective is that whenever possible, a gross total resection should be achieved and should be the goal of therapy for all stages. So this is going back to this series from the Annals of Thoracic Surgery, 2003, and this is a very large sort of conglomeration of data from a lot of institutions, now up to 1,300 patients. And interestingly, in this series, this is looking at patients who had completely resected disease, so R0 resections. The addition of postoperative radiation therapy did not seem to contribute meaningfully to recurrence rates. And again, the conclusion of the study was that the extent of the resection, more so than the utilization of postoperative radiation therapy, is the most important prognostic factor, so supporting the desire for an R0 resection. However, this is another series, very similar series, looking at postoperative radiation therapy for completely resected stage 2 or 3 thymoma, which has a different conclusion. If we see just with the box on the lower left-hand corner, looking at predictors of disease-free survival, the addition of radiation therapy in this series actually did predict for improved outcomes. Whoops. So just to sort of review what we've hopefully come to see so far is that for stage 1 disease, I think the data across the board going back many decades now clarifies that an R0 resection is sufficient for stage 1 disease, and there's really not a role for postoperative radiation therapy. For stage 2 disease, though, we really have had, up until the present, very conflicting data, with some showing a benefit to postoperative radiation therapy and other data showing that there really hasn't been a benefit. We think that the differences probably relate, number one, to the era in which patients were treated. And then, as we talked about earlier in the presentation, the sort of the lack of the quality of the data and not really having a lot of clear understanding from these studies that have been published about the extent of stage 2 versus 3 disease and staging considerations, particularly over the different eras. So the International Thymic Malignancy Interest Group database is the most recent and probably the most important updated publication in thymoma for radiation. And this was a result of, obviously, an international collaboration that specifically tried to hone in on this area of confusion in stage 2 and 3 disease, and looked at patients with Masoka stage 2 to 3 disease who had had R0 resections. Now, what is important about this data set is that it was large, 1,200 patients, and nearly 70% or 2/3 of the patients had stage 2 disease. And so this is probably the best data set that we have specifically for patients with stage 2 disease. It also did include the WHO grade A, B, B, and it had a relatively large proportion of patients with B-type thymomas. And about half of the patients received postoperative radiation therapy. But in this data set, there was a very significant and very clear benefit to the utilization of postoperative radiation therapy, with improvements in both 5-year survival and 10-year survival. And again, thinking about the fact that this data set was, had a very large number of patients with stage 2 disease. So these are the Kaplan-Meier curves. And this is looking at really all of the patients in the data set, stage 2 and 3 together. And we can see a separation in terms of overall survival with the addition of postoperative radiation therapy. And then we have 2 separate curves that try to break out the differences between the 2 stages to see if one is sort of driving more than the other. And we see actually quite similar curves between stage 3 disease here and stage 2 disease. The benefit was slightly smaller in stage 2 disease, but still a very clear benefit favoring the utilization of postoperative radiation therapy. So up until this data was published about 2 years ago, I would say we used radiation for stage 3 disease quite routinely, and for stage 2 disease much more rarely. But we really have had a shift in terms of increasingly recommending postoperative radiation therapy for completely resected stage 2 disease. But as I mentioned a little bit earlier, looking at the images of the staging, we tend to think that we see the greatest benefit in those patients with 2B disease and with invasion into the mediastinal fat. So on the pathology report, that's one of the main criteria that we are looking for to help us determine whether to recommend postoperative radiation for stage 2 disease. With respect to dose, we see that it's important to get a dose of at least 45 gray in postoperatively, and this is just a data set showing a survival separation by dose in postoperative radiation therapy. Our typical dose that we use is around 50 gray. We usually do 2 gray per fraction to 50 gray in the setting of an R0 resection. But we know that we aim to get a minimum of 45 gray. So for these patients with stage 2 disease where we're sometimes a little bit uncertain about whether to recommend the radiation, we will take into account not just the stage, which the data that we looked at previously included, but also we'll look at the WHO grade, stage 2A versus 2B, as I mentioned earlier, a patient's age, and patient preference as well. We'll look at patterns of recurrence a little bit later on in the talk, but the pattern of recurrence often is in terms of local failure, and so there are some patients who will just say they want to avoid radiation therapy and use it in the setting of a recurrence, and that certainly is a factor that we consider as well as the patient preference. So now shifting over to more advanced stage 3 disease, what we would consider unresectable stage 3 or stage 4 disease. Frankly, we sort of defer to the surgeon to tell us what is resectable versus unresectable because they're the person who has to carry that out, and we've established earlier in the talk that the primary goal is to achieve an R0 resection. So if the surgeon is in doubt as to whether that can be accomplished with upfront surgery, we rely on that perspective. Generally speaking, though, we're looking at basically invasion into great vessels and pericardium to kind of define something as at least initially unresectable. And when we have unresectable or stage 3 or stage 4 disease, as we've looked at with the previous talks, we really view systemic therapy for induction as the backbone of the treatment, with the goal to convert the patient to being resectable. So the most common practice is to recommend preoperative systemic therapy. And we can see this is just a table of a number of series that have looked at the response rates with different regimens for preoperative systemic therapy, most often cisplatin-based or at least platinum-based regimens. And the response rate in terms of reducing the size of the tumor to become smaller at least is quite high, probably in the neighborhood of 70–75%, and the ability to convert patients who are thought to be unresectable into resectable may be as high as in the neighborhood of 50%. So we generally would rely on systemic therapy as the first intervention in patients who have what is deemed as unresectable disease. And this is just an algorithm that is developed by the MD Anderson Cancer Center that just looks at their approach for patients who have unresectable disease, beginning with induction chemotherapy, and then ideally followed by surgical resection and radiation therapy in the adjuvant setting. And so I would say that this is the most common paradigm that we will use in patients who present with unresectable disease. In their series, they were 76% of the patients who had presented with unresectable disease subsequently became resectable. And I just use these tables just to highlight that in patients who ultimately have resection, overall survival can be excellent. And so these are, even though these are locally advanced disease, since thymic malignancies often have a favorable prognosis overall, survival can still be excellent with this approach. There are some consideration in some of these cases for doing induction chemoradiation instead of just induction chemotherapy. And we tend to reserve this for patients who have disease that is, really, really sucked in, really unlikely to become resectable with just chemotherapy alone. And this is just an example of a paradigm where patients undergo concurrent chemoradiation, very similar to a lung cancer approach with cisplatin and etoposide, with the goal of converting disease to resectability. This is just an image showing an example of a patient that presented with a very large thymic tumor. This patient underwent preoperative chemotherapy and had only a 10% reduction in the volume of their tumor with the chemotherapy and was felt to still be unresectable. And so then the patient went on to radiation preoperatively, and with that intervention had an overall 90% reduction in the tumor volume, and subsequently was felt to be resectable at that time. So this is a strategy that we will employ in certain cases when patients either don't have the response that we would like to preoperative systemic therapy, or basically continue to be not thought to be resectable after induction chemotherapy. But the data from series that use concurrent chemoradiation instead of just chemotherapy are quite similar in terms of the statistics, in terms of the conversion to resectability and the response rate. So generally speaking, we view the addition of radiation therapy in the preoperative setting as having in most cases, a modest benefit. And so again, we favor preoperative systemic therapy as the backbone, and we'll use chemoradiation in those patients who appear to be resistant or remain unresectable. I wanted to talk for just a few minutes about technique. We do use intensity modulated radiation therapy in the setting of thymoma in most cases. And this is an example of an intensity modulated plan that is basically targeting the postoperative bed. We either will use ARC, VMAT or ARC therapy, or fixed gantry intensity modulated radiation therapy. But we find that we are able to better spare lung and heart, and often esophagus with this approach. So this is just another case of a patient who presented with a very large, this was actually a thymic carcinoma. And this is just an image from the preoperative CT scan. The patient subsequently had induction chemotherapy, the tumor shrank, and was able to go on to surgery. And I used this case because it was one that we debated about within our group. You can see here, we talked, I vaguely was able to follow, thanks to Dr. Belasemi, the discussion about clips. And so we can see here that there are surgical clips that were left in the postoperative bed in this particular case. We debated within our group whether our radiation volume should only include the surgical bed in the area where the tumor had originally invaded mediastinal fat, versus to encompass the entire area where the tumor was in contact with the chest wall, as you can see from this preoperative image. And so this is something that we do debate about, because obviously extending the field is going to extend the normal tissue exposure. We, in this case, relied heavily on feedback from the surgeon, who had described that the capsule was very adherent to the chest wall. There was no invasion in this particular case of the pleura, but the capsule of the thymoma was very socked in and adherent to the chest wall. And ultimately, we opted to use the entire preoperative volume as our target, so including the area of invasion of the mediastinum, but also the entire sort of lining of the pleura where the thymoma had been previously located. And with intensity modulated radiation therapy, we're able to sculpt the radiation dose to a certain extent so that it sort of follows the curvature of the target. And this is just a PET scan for this particular patient, helping us to do that target delineation and showing one area in particular where there was some questionable invasion. And then just some more images of the radiation field, basically using the preoperative imaging in order to target all of the areas that the tumor was in contact with preoperatively, but sculpting out lung tissue that was not felt to be at risk. And this is coming inferiorly along the heart. So this International Thymic Malignancy Interest Group has published some dose constraints, and I'm not going to go through them in detail, but you can look up this publication or take a picture of the slide. But what I think is important is that there are slightly different but very similar constraints for patients who have had surgery versus those who are getting radiation therapy alone. In general, the difference is that the lung dose constraints are more strict in patients who are going to be having surgery or who have had surgery. But we look primarily at the mean lung dose and the V20. And you can see that these are relatively similar to lung dose constraints. For the heart, the mean dose constraint is 26 gray. And we can contrast that very sharply with what we were just talking about in the setting of breast cancers, where I talked about doses of 4 gray or hopefully lower. One of the points that I want to make is that I think that with the use of intensely modulated radiation, it of course depends on the target, but we can very often do better than a mean heart dose of 26 gray. We've seen from the breast literature as well as from thoracic literature that heart dose does correlate with long-term cardiac outcomes. And we also established earlier in the presentation that patients with thymic malignancies, even those with stage 3 and 4 who become resectable in particular, do have a pretty favorable long-term survival. And so I think it's particularly important for us to be cognizant of the cardiac dose, which is, I think, a little bit more of a modern way of thinking about treating thymoma, where the heart is almost always getting some significant exposure. So from the treatment plan that we just looked at, this is the dose volume histogram. Because this was a postoperative R0 resection, our prescription dose was 50 gray. And I took off a lot of the different structures just to make the DVH not so complicated. But I wanted to just point out the red curve is the heart dose, and the mean heart dose in this case was 17 gray, even though when we look back, really the radiation field sort of had to sculpt around the heart the whole way. We were able to get a dose that was significantly lower than what the recommended dose constraint was. And then for the bilateral lung, the V20 was a little bit under 25%. So we were able, using intensely modulated radiation, even with this relatively complex field, to stay well within the established dose constraints. Then the last thing that I wanted to just present, and I don't know why the name is twice there, I'm sorry, but just looking at patterns of failure, I think this is particularly important as we make this shift from looking at the 3D conformal approach to thymic malignancies versus intensely modulated radiation therapy, where we're really targeting a very specific postoperative bed in majority of cases. And so this is just a series that looked back at 34 patients with thymic malignancies who had developed recurrences locoregionally, and looking at where those recurrences happen. And it was very interesting to see that a small number, but some recurrences were in-field recurrences, suggesting that the radiation dose was inadequate, or that the tumor was radiation resistant, or in some way the treatment approach failed despite the fact that the target was appropriate. Only one of the failures was considered a marginal failure at the edge of the radiation field. And then the vast majority were out-of-field recurrences. And this is just another cartoon that shows the blue dots are the out-of-field recurrences. So really it can occur kind of anywhere along the lining of the pleura or anywhere in the thoracic cavity. But I think this sort of supports the idea that our targeting a postoperative bed with more conformal approaches is very reasonable in light of the fact that we can often improve the dosimetric parameters of the treatment plan, and that the majority of failures, if they are going to happen, are going to be outside of the radiation field. field, generally speaking. So just to conclude, we just have summarized that in stage 1 thymoma, we really do not recommend the utilization of postoperative radiation therapy. In all patients with stage 2 or 3 disease, we at least consider the addition of postoperative radiation therapy. And in our practice, based on the data that I showed you, we have really moved towards recommending postoperative radiation therapy in the majority of patients with stage 2 disease, although more so in stage 2B than 2A. But we still have a relatively limited understanding of all of the features that could help us, hopefully in the future, to identify which ones are going to benefit the most from postoperative radiation therapy. When we have patients who present with unresectable disease, we generally begin with preoperative systemic therapy and move to chemoradiation in patients who respond poorly or have persistently unresectable disease. We tend to reserve radiation therapy for the postoperative setting, but there are institutions that are investigating the preoperative chemoradiation strategy, as is done more commonly in lung cancers. So that concludes my talk. I'll take any questions. Thank you.